My name is Randolph Brehler. I'm working here at the University Hospital of Münster. I am responsible for the Department of Allergy here. And we have a lot of patients suffering from allergic rhinitis, suffering from allergic asthma, but also from urticaria and atopic dermatitis, for example. For me, it's really very important that allergy normally starts with a sensitization to one allergen. And here frequently to important allergens, and these important allergens are frequently the major allergens. And this means over the time patients may become sensitized to several other allergens. Normally we have in an allergen extract different components, and some of these components are really specific for one allergen thus. For example, this is for the birch pollen allergen, the so-called BET-V1 protein. Nevertheless, we have in these proteins or in these extracts also other proteins, and these may be minor allergens, and especially these allergens may be cross-reactive. And this is meaning allergy, for example, against birch pollen allergy will normally start with BET-V1 allergy, and then the patient may become really allergic. Over the time he will become sensitized, for example, to BET-V2 and BET-V4, to the profilin, for example, and these are cross-reactive allergens. Therefore, he will show a cross-reactivity or a cross-sensitivity, for example, to grass pollen, to mugwort pollen, and so on. Therefore, nowadays we have to decide, is allergy really a primary allergy or is it more a cross-sensitivity? Treatment for allergic rhinitis and also for allergic asthma is recommended nowadays over a period of about 3 to 5 years. It has been demonstrated by some small trials that more than 3 or 4 years maybe not have an additional benefit for patients. These are some trials, and we know some individual patients will suffer also from a longer therapy. The more important question is a shorter therapy possible? And it has been demonstrated that there is clinical efficacy already after the first year of therapy. There is normally more effect in the second and the best efficacy in the third year. Nevertheless, some patients may become nearly symptom-free also after 2 years of therapy. But there are again some small trials, and they demonstrated, yes, you have efficacy, therefore symptoms will be suppressed, but nevertheless the question is, will treatment have a long-term effect? And the long-term effect needs a longer therapy. And therefore, nowadays the thought, treat patients 3 to 5 years for the long-term effect. This means after stopping therapy, the treatment will be efficacious over the next years, and that is important for our allergic patients. Immunotherapy needs an updosing protocol. And nowadays we have here in Europe standardized preparations, and for these standardized preparations we have fixed updosing protocols. The updosing protocol is necessary to reach the maintenance dose. And the maintenance dose nowadays means that we want to reach a so-called optimal dose. This means a lower dose will have less efficacy, a higher dose will not have more efficacy. And in big clinical trials it has been demonstrated that nearly all the patients can tolerate this optimal dose. If individual patients cannot tolerate it, then I would recommend stay at a bit lower dose, but about 3 months later try again to updose the dose to reach the maintenance dose. Then you will have the optimal effect, and then you will have a long-lasting effect of immunotherapy.